Dr. Io had mentioned that alcohol use disorder is common, and one of the main complications that can happen in people who drink chronically and excessively is liver disease. So I'll be talking about alcohol-associated liver disease, which actually accounts for about 30% of all alcohol-related deaths. So one of the most common causes of deaths directly attributable to alcohol use. I'll be talking about the epidemiology of alcohol-associated liver disease, and then we'll talk about diagnosis and management, mostly focusing on alcoholic hepatitis because I think that's where a lot of the newer information is, as well as the role of liver transplantation for patients with alcoholic hepatitis, and then just a few brief comments on treating AUD in this patient population. So to start off with, Dr. Io had clearly shown us that AUD is very common in the US population. This is just one slide demonstrating in another way how common it is. So this is data based on national epidemiologic surveys. In the blue, you're looking at prevalence rates of AUD in 2001 to 2002, and then in the orange, you're seeing 2012 to 2013. And in this time period, all the way on the left side, you can see there was growth, and that this held true across both sexes, various racial groups, and age categories. Just to point your attention to this, I don't know if it's projecting, but the 18 to 29-year-old group, you can see in 2012 to 2013, almost 1 in 4 young adults met criteria for alcohol use disorder. So that's really alarming to me. This increased trend continued throughout the COVID-19 pandemic, where surveys showed that 60% of US Americans reported an increase in the amount of alcohol they were drinking, as well as the frequency they were drinking alcohol. So it's continuing to grow, and we've seen that in our clinics and in the hospital as well. With this growth over the past couple of decades, we've also seen an increase in the prevalence of alcohol-associated cirrhosis. So this is data coming out of an administrative claims study of privately insured US adults. And over the study period from 2009 to 2015, there was a 37% increase in alcohol-associated cirrhosis. On the right side, you're seeing this overall trend in both men and women with prevalence rates going up. With growth of alcohol-associated liver disease, it is now the most common indication for liver transplantation. So in 2016, alcohol-associated liver disease made up about 37% of all liver transplants performed. And that trend has continued in the more recent years, not depicted on this graph. Part of this rise in the last handful of years is after the introduction of direct-acting antivirals, where we're no longer transplanting as many people for hepatitis C-related liver disease since we're able to cure them, and some of these patients are doing better after viral cure. But we also have seen an increase in transplant for alcohol-associated liver disease because we're now transplanting more patients for alcoholic hepatitis. And that's really following the publication of a seminal study in the New England Journal in 2011, where there was a survival benefit demonstrated from early liver transplantation for severe alcoholic hepatitis. So we'll talk a little bit more about that later on. When we diagnose patients with alcohol-associated liver disease, number one, we have to be able to identify the presence of heavy alcohol use. So Dr. Io clearly walked us through different screening mechanisms using validated questionnaires and biomarkers. I want to just go into biomarkers a little bit more because, like he mentioned, we tend to use these more and more. The bottom for the ethyl glucuronide and the ethyl sulfate and the phosphatidylethanol, or PEth, are not affected by liver disease, so they are the preferred biomarker tests in our patient population. At Vanderbilt, we use this bottom one, the phosphatidylethanol, or PEth test, and it has the added benefit because it has a long detection window of 2 to 3 and sometimes up to 4 weeks if somebody has drank chronically and heavily. It is prone to a lot less false positives than our other biomarkers. And like Dr. Io mentioned, the degree of elevation tends to correlate with more severe drinking. So the higher the PEth level is, tends to reflect heavier drinking. So it's a very useful test that we use to screen people in our liver clinic and also use to monitor over time. One of the reasons we rely so heavily on biomarker testing is because patients self-report is subject to recall bias and also just a lot of underreporting, especially when they're coming to see us in clinic. As you can imagine, someone might be a little afraid that if they disclose a lot of alcohol use, it might impact their care or their transplant candidacy. So just to highlight the importance of biomarker testing, this is data coming out of a study looking at patients with cirrhosis evaluated at a liver transplant center, and they administered self-report questionnaires questionnaires and also performed biomarker testing for all of these patients. In this table, we're just looking at the 34 patients who had a positive PEth test. And you can see that among these 34, only 6 patients reported any alcohol use in the preceding month. Okay, this is just one small study, but you can see in this study, if we had only relied on self-report, we would be missing the large majority of patients participating in active alcohol use. So if you detect high-risk drinking, whether through questionnaires or biomarker testing, I would encourage you to think about screening for liver disease, and that might just be by physical exam, some routine lab tests, or considering an abdominal ultrasound. And what you find on those tests really will depend on whether or not they have liver disease and where along the spectrum they fall. Simple steatosis is the earliest form, and it occurs in about 90% of patients who participate in heavy alcohol use. At this point, if someone is able to completely abstain from alcohol use, the steatosis can completely resolve within as little as 4 to 6 weeks. So quite remarkable. But if patients continue to drink alcohol, there is a subset that will go on to develop more progressive forms of disease, including steatohepatitis and varying degrees of fibrosis or scarring. And it can ultimately lead to cirrhosis and hepatocellular carcinoma, or HCC. There's a separate entity called alcoholic hepatitis. It's largely a clinical diagnosis. It can happen along anywhere on the spectrum of disease, but more frequently occurs once somebody has developed some degree of fibrosis, and more commonly occurs in the setting of underlying cirrhosis. More specifically, alcoholic hepatitis is defined as the onset of jaundice in the prior 8 weeks. It requires ongoing consumption of excessive amounts of alcohol, and there are certain gram cutoffs there. So more than 40 grams for females, more than 60 grams for males, and that's alcohol per day. But what I do want to point out is if you can still develop alcoholic hepatitis if you've just recently stopped drinking. So by definition, you can have not had any alcohol for up to 60 days, still present this way, and it meet criteria for alcoholic hepatitis. The AST and ALT are elevated in a ratio greater than 1.5, and both of those enzymes are less than 400, and then the bilirubin is greater than 3. So if you have a patient who comes and they have all of these criteria, they probably have alcoholic hepatitis, and there's no need for a liver biopsy. But say you have a patient who comes in jaundice, the liver enzymes look like they might match the ratio here, but it's a little bit abnormal. We're not sure about the alcohol use history, or there's some confounding factors, like maybe they took some medications that were possibly hepatotoxic, or there's a question about infection. Well, if we're not really sure about the picture, then a biopsy is recommended to confirm the diagnosis. Alcoholic hepatitis occurs in about 30 to 40% of patients who participate in chronic heavy alcohol use. And if somebody has severe alcoholic hepatitis, there's about a 90% chance that they already have cirrhosis. It's considered the most serious form of alcohol-associated liver disease and has very limited treatment options. And there is a very high short-term mortality associated with this condition, especially in its severe form. So severe alcoholic hepatitis is defined by a Maddrey's discriminant function greater than 32. You can just put that into MD Calc or look it up online. Or a MELD score of greater than 20. And you can see here, a 28-day mortality rate can be as high as 50% for these patients. So it's very, very serious. In a person who has medically refractory disease, meaning you offer them the treatments that we have and they don't have any improvement, their 1-year mortality is up at 90%. This is in stark contrast to people with non-severe alcoholic hepatitis who have a 28-day mortality of about 6% and then a 1-year mortality of 13%. So those numbers, I would argue, are still relatively high, but much better than those who have severe alcoholic hepatitis. When we think about managing patients with alcohol-associated liver disease, if they have early stages of disease, steatosis or just early fibrosis, maybe their liver enzymes are just a little bit elevated, really the mainstay of treatment is alcohol cessation and permanent abstinence. If you have more advanced forms of disease, like cirrhosis, or you develop alcoholic hepatitis, then management considerations involve a few other things. So in the setting of cirrhosis, we for the most part address these patients just like anyone with cirrhosis from other etiologies. We manage hepatic encephalopathy, ascites, variceal bleeding complications. Everyone should undergo liver cancer screening every 6 months with appropriate imaging, plus or minus an alpha-fetoprotein test. And then I like to make sure all of my patients are vaccinated or immune to hepatitis A and B. If alcohol has played a role in their liver disease, then abstinence becomes key. So this figure here on the right side is looking at data of patients with decompensated cirrhosis, and they looked at survival outcomes based on a patient's ability to achieve abstinence 1 year following diagnosis. So the top line are those who were able to achieve abstinence versus the solid line, patients who continue to drink. In those who were able to abstain from alcohol, there was a 28% mortality at 7 years versus 66% mortality at 7 years in those who had ongoing alcohol use. Now the other thing to look at, and if you look at this figure at the 1 year mark, still, even if you're able to abstain from alcohol, a good portion of patients are still dying within 1 year. So if a patient is able to stop drinking but they continue to have decompensated disease, then a liver transplant really should be considered for these patients. Now for the rest of the management section, I'll be talking about alcoholic hepatitis, which is really a multi-pronged approach. First, you think about the alcohol use related complications. Like Dr. Io had talked about, withdrawal is very important to monitor for and treat. Withdrawal can be very severe and life-threatening if not treated. We like to make sure these patients get engaged with addiction psychiatry and have AUD-directed treatment early on. And then also mentioned were that these patients who chronically drink alcohol are prone to micronutrient deficiencies, so we like to assess for those and replace as needed. Some general measures: these patients, like patients with cirrhosis, can develop portal hypertensive complications that need to be managed. And then people with severe alcoholic hepatitis are prone to infections and acute kidney injury, which I'll talk a little bit more about. For the alcoholic hepatitis specific measures, again, alcohol abstinence is the most important thing. Now, I like to highlight that I think nutritional supplementation actually comes next, and then corticosteroids should be considered after that. Severe alcoholic hepatitis is associated with a high risk of infection. So in one prospective study of about 250 patients, they systematically screened for infection in patients who were hospitalized at a tertiary care center. And they found, when they did chest x-rays and cultures on everyone, that about 25% of patients had infection at the time of admission. So 1 in 4 people coming into the hospital with severe alcoholic hepatitis had infection, and many of those had no signs or symptoms at all. And infection was associated with increased mortality. So it's important to be very vigilant, do the screening for infection, and treat if they have an infection. The other complication that's really common in severe alcoholic hepatitis is acute kidney injury, and this occurs in about 50% of patients with severe alcoholic hepatitis. It's associated with an increased risk of mortality as well. Now, this figure on the left-hand side is really to emphasize the fact that there are many, many reasons for acute kidney injury in the setting of severe alcoholic hepatitis, and only one of those causes is hepatorenal syndrome. I think a lot of times we tend to think, oh, decompensated cirrhosis or a bad liver disease and AKI, it's definitely hepatorenal syndrome, but actually more often than not, it is something else. In an effort to try to avoid or treat acute kidney injury, again, emphasizing the need to evaluate for and treat infections, avoid any nephrotoxic agents such as contrast and NSAIDs. A lot of these patients come into the hospital very volume overloaded. They're anasarchic, everything is swollen, and I think we often want to dry them out, give them a lot of diuretics, but that just increases their risk of acute kidney injury. So if they're not having respiratory compromise and they can live with the fluid overload for a few days, I would say to use diuretics very judiciously and to have a very low threshold to expand their intravascular space with albumin. And then finally, dialysis is appropriate in select cases, and that's a very nuanced, kind of complicated decision, so I won't go into that today, but it should be considered in some cases. Going to alcoholic hepatitis specific measures, alcohol abstinence is the most important. You're going to keep hearing me say that over and over again. This is data coming from a study of 142 patients who survived a first episode of biopsy-proven alcoholic hepatitis. Out of those patients, 39% were able to achieve complete abstinence, and complete abstinence was independently associated with improved survival. The other point here is that alcohol abstinence is actually the only proven intervention to improve long-term outcomes for our patients. Nutritional supplementation arguably is the next most important thing. So this is data from a meta-analysis of 13 studies where they evaluated nutritional supplementation to meet 75% of a patient's daily caloric needs. And in this meta-analysis, they found that that type of nutritional supplementation was associated with a 20% reduction in overall mortality, as well as fewer episodes of hepatic encephalopathy and fewer infections. So studies like this and a few others really support our overall recommendations now. In severe alcoholic hepatitis, we aim for a daily caloric intake of 35 to 40 kilocalories per kilogram of ideal body weight per day, and a daily protein intake goal of 1.2 to 1.5 grams per kilogram of ideal body weight per day. It's hard to really understand what that means, but that's very high calorie and very high protein. I would never get that in my daily diet unless I was being very intentional about what I was consuming. The other point here is that many of our patients are severely ill. They don't feel well. They may be in the ICU and they have no appetite. So oftentimes we need to consider putting an enteral feeding tube in and giving them some supplemental tube feeds. And then finally, corticosteroids. Corticosteroids are the most studied pharmacotherapy for alcoholic hepatitis. And there's few studies out there that support its use, but I would say that the data is actually a little bit limited, and it's limited by heterogeneous patient populations that make it difficult for us to conclude whether or not steroids should be used for people. The largest study out there is an RCT out of the UK containing 1,100 patients, and in their post-hoc analysis, they found a 28-day mortality benefit related to corticosteroid use, but that survival benefit did not stand at 90 days or 1 year. Similarly, a meta-analysis of about 1,000 patients demonstrated also a 28-day mortality benefit from corticosteroids. But you can see on the right-hand side, while there statistically was a benefit, I think it was I would say that it was a modest benefit. There's also potential harms to steroids that need to be considered. So steroids lower our immune system and they make us more prone to infection. So using the STOP-AH trial data, the investigators found that being treated with steroids, while it did not increase infection rates while on steroid therapy, there was an increased risk of developing an infection after steroid treatment. And that incident infection was actually associated with increased mortality, where it almost more than doubled the odds of mortality. Other studies have also showed that about 50 to 60% of patients who are treated with steroids actually don't have any biochemical response to the steroid therapy. So the data showing benefit is a little limited, and then we know that there are potential harms. And this all put together has led to a few groups looking at how we can possibly find exactly who is going to benefit from steroid therapy and minimize harms at the same time. So one of the things that has recently been looked at is the neutrophil to lymphocyte ratio, which is just a calculation based on what we see on our CBC with DIF. This ratio goes up in periods of stress, such as inflammation and infection. And what they did was they looked at the STOP-AH trial data again, and then also used a validation cohort, and they found that people with a neutrophil to lymphocyte ratio greater than 5 were the ones that had more biochemical response to prednisolone therapy. However, once that ratio rose above 8, they started to see more rates of infection and AKI. So taking these two things in mind, when they looked at overall mortality, they found that people who had a baseline neutrophil to lymphocyte ratio between 5 to 8 were the ones that derived survival benefit from prednisolone therapy. So this suggests that maybe we can use the neutrophil to lymphocyte ratio to more tailor our treatment for these patients. Putting this all together, when we have a patient with severe alcoholic hepatitis, we think about managing their withdrawal, getting them into AUD treatment early on, assessing their nutritional deficiencies and considering supplementation, and then considering corticosteroid therapy. Arguably, only in patients with severe alcoholic hepatitis, and then arguably tailoring that to patients with a neutrophil to lymphocyte ratio between 5 and 8. Now, if somebody does not have any contraindications to steroid therapy, then we start them on prednisolone 40 milligrams per day, and then we calculate something called the Lille score after 7 days. That's also a free calculator that you can get online. But after 7 days, if the Lille score is less than 0.45, those patients are considered steroid responders, and they have a favorable 6-month prognosis with a survival of about 85%. In contrast, if the Lille score is 0.45 or higher, those patients are considered steroid non-responders, and studies have shown that their 6-month survival is low at 25%. So if somebody is not a steroid responder, or they're not a steroid candidate and they are getting clinically worse, then it would be appropriate to consider whether or not they could be considered for a liver transplantation. So who is eligible for a liver transplantation for the indication of severe alcoholic hepatitis? Historically, probably nobody. So until recently, liver transplant centers in the U.S. required what's called the we used what's called the 6-month rule. We required a minimum 6-month period of alcohol abstinence before a patient would be eligible to be considered for liver transplantation. And the thought behind that was twofold. So 6 months we thought would be enough time for patients to demonstrate their commitment to abstinence. And then also when we remove alcohol from the equation, some patients with bad liver disease get better over time. So we thought, okay, you monitor them and you might weed out the patients who no longer need a liver transplantation. Now, when we think about severe alcoholic hepatitis and the patients who have medically refractory disease, I said that their 6-month survival is only 25%. So we're really not giving these patients a chance. So while we think now that longer periods of abstinence reflect a lower risk of relapse, we know that the 6-month rule is not an adequate predictor of relapse and cannot be used alone. So there are a lot of different factors that we consider, such as the patient's age, their social support situation, whether they have comorbid psychiatric disease, other substance use, and then factors about the alcohol use itself. How much were they drinking? How long have they been drinking? And things like that. With this in mind, a group in France and Belgium started to offer early liver transplantation for people with severe alcoholic hepatitis refractory to medical therapy. They used very strict selection criteria in who they offered a liver transplant to. And you can see here, the patient had to be coming in for their first ever liver decompensation event. So they could not have any knowledge of any prior existing liver disease. They had to have the presence of close supportive family members. They had to have the absence of any severe coexisting or psychiatric disorders. And they had to agree to adhere to lifelong alcohol abstinence. The decision to list them had to be unanimous amongst everyone on the selection committee. And just to give you a sense of how strict they were in selecting their transplant candidates, after thinking about everyone coming to their hospitals, only 2% of patients underwent transplantation, and that amounted to 26 patients. When looking at their outcomes, those who were transplanted had a 6-month survival of 77% versus only 23% in matched controls who did not undergo transplantation. Of the 26 transplanted, at a 2-year follow-up, 3 of them had alcohol relapse, and none of them had any problems with their allograft function. So small study, but promising. And the uptake for early transplant in France was pretty immediate. In the US, it led to further pilot studies, and our experience was published out of the Accelerate AH cohort about 7 years later. In this study, they included 12 transplant centers across the country, and they transplanted 147 patients with a median alcohol abstinence period of 55 days. Outcomes were pretty favorable, so 1-year survival of 94% and 3-year survival of 84%, and these outcomes are actually similar to liver transplants being performed for other indications. They also looked at rates of sustained alcohol use after transplant and found 10% of patients had relapsed in a sustained fashion at 1 year and 17% at 3 years. And these relapse rates also similar to relapse rates in patients who were transplanted for alcohol-associated cirrhosis following that 6-month mandatory abstinence period. Sustained alcohol use after transplant was defined as using alcohol for more than 100 days after their liver transplant, and it was associated with increased mortality. Now, this can be for various reasons. Drinking may lead to non-adherence. It can lead to recurrent alcohol-associated liver disease and cirrhosis. It can lead to rejection by way of non-adherence with their immunosuppressive medications. So this is why we care so much about how we can identify patients who are at higher risk of relapse. Using this Accelerate AH cohort, the investigators tried to come up with a predictive calculator or a predictive score to predict how we can identify who's at higher risk of relapse or not. And they identified these 4 variables. So if someone is drinking more than 10 days per week at time of presentation, it gets them 4 points. Having 2 or more prior failed rehab attempts, 2 points. A history of alcohol-related legal issues, failed rehab attempts is 4 points. A history of prior alcohol-related legal issues at 2 points, and then a history of non-THC illicit substance use at 1 point. And they found that a SALT score, that's what this is called, the SALT score of greater than 6 performed the best at predicting patients who would have sustained relapse after transplantation. So this is just one predictive score that's used. There's various models out there and predictive scores that other transplant centers and programs try to use. None of them are perfect, and so we shouldn't rely just on one score, but it does go into our protocol. So at Vanderbilt, we started to offer early liver transplantation for severe alcoholic hepatitis in 2020. And at our center, it's pretty similar to the criteria in the French study, but patients have to have severe alcoholic hepatitis that is medically refractory to corticosteroid therapy, or they are not a corticosteroid therapy candidate and have progressive disease. Their presentation has to be a first ever liver decompensating event, and we as providers have to believe or think that they're not expected to survive through any required AUD treatment prior to a liver transplantation. Additionally, they have to be able to participate in the evaluation, and they have to demonstrate adequate insight into their addiction. The patient and their family signs a contract that they are going to attend addiction treatment post-transplant, and this includes an intensive outpatient program and AA that we'll hear more about, as well as the use of pharmacotherapy. The patient agrees, along with support from their family, to lifelong alcohol abstinence. They have to have supportive, sober family members. Okay, so their family members also have to be sober. And they have to have the absence of any untreated coexisting psychiatric disorders. And I mentioned the SALT score, so we do include it in our transplant protocol where a patient has to have a score of 6 or less. So if somebody's SALT score is greater than 6, they are not a candidate for early transplantation at Vanderbilt. We do our best to try to find patients who are at low risk of relapse, but relapse happens. So after transplant, we use a multimodal approach to screen and prevent and treat alcohol relapse. We ask them routinely at follow-up visits. We use PEth testing at every follow-up visit. We often require the use of pharmacotherapy for AUD specifically, and then our transplant psychiatry team follows up with them regularly, and then they make recommendations about whether a patient needs referral to an addiction specialist or not. Along the lines of management of AUD, just a couple of points for our patients with liver disease. We know that AUD treatment benefits patients with liver disease. Now, this is a VA cohort of patients with cirrhosis who had an index diagnosis of AUD, and they looked at whether or not patients received AUD treatment as well as their clinical outcomes, and they found that any AUD treatment was associated with reduced liver decompensation and reduced mortality. Now, what's a little bit depressing in this study is that only 14% of patients were started on any AUD treatment at all, and that's similar to what Dr. Eo had demonstrated to us, where 10% of patients with AUD in the US received treatment. So we need to do better. In a cohort of patients with severe alcoholic hepatitis, we also found that early alcohol rehabilitation led to reduced readmissions, reduced alcohol relapse, as well as reduced death. So both of these studies are just examples that really highlight the importance of early alcohol rehabilitation and AUD treatment. Pharmacotherapy, we already touched upon this. You'll see that disulfiram is not on this table, and that's because it's contraindicated in the setting of liver disease. And then Dr. Eo also mentioned the potential for hepatotoxicity with naltrexone, so we are cautious in using that in patients with more advanced liver disease. And then I like to just highlight baclofen. It is not FDA approved for the use of for treatment of AUD, but it does have at least one RCT for patients with liver disease, so it is something that I keep in my back pocket. Since I'm not super comfortable prescribing the other things, at least is something that I can offer my patients. Just to make a point, treating AUD requires a multidisciplinary approach. We talked about pharmacotherapy, which I think can be offered by many practitioners, does not have to be with an addiction specialist. Behavioral therapy, we will hear all about that next. And then just the point that we have to make sure we are identifying and addressing comorbid psychosomatic disorders. Studies have also shown that patients with liver disease often have depression and anxiety, chronic pain issues, and insomnia. And if we don't treat these issues, they often serve as triggers for relapse. So this needs to be part of the treatment algorithm as well. So in conclusion, alcohol use disorder is common, and it contributes to the rising prevalence of alcohol-associated liver disease with an increasing burden on our healthcare system. Alcohol cessation is the most important factor for survival in alcohol-associated liver disease. Treatment options for alcoholic hepatitis are limited, but the benefits of corticosteroid therapy may be limited to select groups and of limited duration. Liver transplantation should be considered for select patients with medically refractory severe alcoholic hepatitis who have a lower risk of relapse, and multidisciplinary integrated management of alcohol-associated liver disease and alcohol use disorder is recommended, and it improves rates of alcohol abstinence among patients with alcohol-associated liver disease. This is just a picture of all of the hepatologists at Vanderbilt. We have doubled in size over the past 3 years, so many faces may be new to you all, but we are all available if anyone has any questions or would like to send patients our way.